Everyone, this is Dr. Anmol Mishra from Radiants, and a few days ago we had posted a question on our Instagram page where we asked you to answer a question for us. So this was the case that we had given, and what you see on your screen is the NCCT image of that particular case. So in this particular video, we are going to discuss in detail what are the differential diagnosis of this appearance, and secondly, we will be discussing how to differentiate or how to rule out the different differentials. So how are we going to do that? First of all, I want you to understand what is the primary area of focus for us. So if you look here, you can definitely understand that the abnormality lies here in the right hemisphenoid sinus. So we can see a well-defined hyperdensity here. So I'll just make things easier for you. I'll just zoom the image here and we'll pan it down towards the center. So what do you see? We can see that there is a well-defined hyperdense lesion inside the right hemisphenoid sinus, right? And along with that, there are some hypodense areas as well, which is occupying the rest of the right hemisphenoid sinus, right? So it's definitely more hyperdense. This area which is different from the hyperdense lesion, this area is also definitely more hyperdense as compared to the air on the contralateral hemisphenoid sinus. So first of all, let's focus on the hyperdense lesion. Okay, so we can see a rounded homogeneously hyperdense lesion which is occupying the anterior part of the right hemisphenoid sinus, and it somewhat seems to be also occupying the sphenoid ostium, right? So that is what we see here. And when we see something that is hyperdense inside a sinus, then immediately there are four differentials that should immediately come to our mind. And these are, first of all, you have to think about the most common thing, that is chronic inspissated secretion. It can be something related to fungal infection of the sinuses, which is the second differential. Third is hemorrhage, and fourth is calcification. So these are the four things that you need to think about: fungal elements, chronic inspissated secretion, hemorrhage, and calcification. Okay, so first of all, the commoner ones, we'll think about that first. So it could be chronic inspissated secretion, but the issue with chronic inspissated secretion here is that you usually do not find chronic inspissated secretion to take such a well-defined rounded ball-like shape. Okay, so that is one thing that is somewhat off with our diagnosis of a chronic inspissated secretion. Secondly, if we talk about hemorrhage, first of all, this hyperdense area, you will find usually an air blood level inside the sinus. You will get a history of trauma, and often you will find associated fractures in the sinus walls. Whereas this patient, who is basically a 59-year-old female, actually presented to us with severe headache. So it's nothing related to trauma. So that also pretty much rules out our next differential, which is hemorrhage. Talking about calcification, it could be calcification, but for that we need to see the HU. So let me tell this to you, that the HU approximately here is between 50 to 70. So the average HU is basically 60, 70, somewhat like that. And we very well know that usually if you find something that is calcified, it usually has an HU of 100 or more. So calcification also seems a bit rare here. So or unlikely here rather. So it's not exactly calcification, it's not hemorrhage, does not exactly look like chronic inspissated secretion. So what could it be? So you should be thinking about something that can take a round shape and can be hyperdense on CT scan. So it could be because of fungal elements. So we started thinking about fungal elements, of course, but you cannot stamp anything as fungal infection just by looking at the CT. I mean, if you're talking about a fungal ball here, so we need the help of another imaging modality, and that is MRI. And thankfully we have that at hand right now, and we will also be looking at the MRI image of this same patient. But before that, I want you to have a look at the bone window first, so that you can appreciate some other changes in the bone as well. Firstly, just have a look at the appearance of the sinus cavity. So here it's pretty much evident that there is something that is opacifying the sinuses, and though we cannot readily differentiate between the hyperdense and the hyperdense part, which was clearly visible in brain window, but at least we can clearly see that yes, in addition to the hyperdense lesion that was present anteriorly, there is also something that is occupying the cavity of the sinus on the posterior aspect. So that also we can see. And secondly, we can also visualize that there is definite reactive bone thickening on the ipsilateral sphenoid sinus wall. If you look at the contralateral wall, look how thin and sharp this is. But if you look at the ipsilateral wall of the sphenoid sinus, we can clearly see that there are features of reactive bone thickening. You won't find any erosion, but yes, definitely there is bone thickening. So this also goes against some of our other differentials. And what am I talking about? You don't find in fracture, so trauma and hemorrhage is kind of unlikely. Yes, this can be chronic inspirated secretion, as I said, but we will be talking about that in detail because there is a catch in this case. So we will talk about that. And if you think about an invasive fungal sinusitis, in case of invasive fungal sinusitis, we usually get bone erosion. If we talk about say allergic fungal sinusitis, then in that case you will usually get multiple sinus involvement, usually in a young patient, and instead of reactive bone thickening, there is actually thinning and expansion of the sinus. So you will find thinning of the sinus walls with expansion of the sinus cavity. That happens with allergic fungal sinusitis. So that is also missing here. So these are certain things that make us think of a non-invasive fungal etiology, also because the patient is immunocompetent, and we know very well that in immunocompetent patients we can have non-invasive fungal sinusitis. So the two variants that we have in non-invasive is allergic fungal sinusitis and fungal ball. And we are thinking of fungal ball here because of a single sinus involvement, which is more common in a fungal ball, and also the patient is old, and there is no history of immunosuppression as such. So these features basically favor the diagnosis of a fungal ball, though we should also bear in mind the diagnosis of chronic inspirated secretion. But I'll show you that and you'll understand much better. So these are zoomed images of the sphenoid sinus. Basically, we went for MRI brain here, also to look for any other cause of headache, if any. And on your screen, you can actually look at. On this side, you can see this is a T1 weighted image, and on the other side, this is T2 flare. If you want to look at T2, I'll show you T2 as well. But first, let's have a look at T2 flare. So if we look at T1 first, what do you see? First of all, yes, we can see that there is some thing that is occupying the cavity of the right hemisphenoid sinus. And if we look here, the intensity is different anteriorly and posteriorly. On the anterior aspect, you find a well-defined lesion that is relatively intermediate to low signal intensity on T1 weighted images, with a relatively hyper intense area that is occupying the rest of the right hemisphenoid sinus cavity. Okay, and if I look at the same corresponding area on T2 flare images, what do I see? The hyperdense area, which I think could be chronic secretion, is pretty much what I am expecting, because you see that this is hypointense. Sorry, this is hyperintense on T1 and hypointense on T2 flare image. It will also be hypointense on T2. I'll show you that as well. And along with that, you can see on this flare image there is mucosal thickening along the walls of the sinus. And in CT scan also we could see that there was thickening of the bone, reactive osteitis, and that tells us that yes, there is definitely some chronic sinusitis kind of procedure going on. So that process is definitely there, but along with that, you can also see here the cause of the fungal sinusitis, the chronic sinusitis that is happening. Why is it happening? That is because of this lesion. Had I not seen the T1 weighted image, that too just side by side, I would have thought that this is probably an ethmoidal air cell, posterior ethmoidal air cell, that has invaginated into the right hemisphenoid sinus, because it's as hypointense as air. And that is what makes you more confident of your diagnosis of a fungal ball, because in fungal ball, the elements of the fungal hyphae contain iron, then other metals like magnesium, manganese, which render this property of marked T2 hypo-intensity, which you can see on T2 flare, and you can also see definitely on T2 as well, and I'll be showing that to you too. So let's have a look at T2 here. So on this side, instead of T1, now we'll be looking at T2 and we will be comparing it with T2 flare. So let me zoom this image as well for you at the same level, and now let's scroll it together. So what do we see? Let's have a look. So this lesion here, if you look carefully, okay, I'll pan this down at the same level. If you look carefully, what do you see? So we see that there is this intrasinus lesion here, which is markedly T2 hypointense, similar intensity on flare as well, with similar findings in the rest of the sinus as we were looking in flare image. Also, you could be thinking of another neoplastic mass inside the sphenoid sinus when you looked at the CT scan image. But let me tell you, neoplastic masses usually do not have an HU as high as maybe 70 or 60, which we got in this case. It can be having a soft tissue density around 30, 40, maybe even 50, but usually it doesn't go beyond that. And secondly, if you look at the T2 wetted image, which is more helpful in differentiating it from a neoplastic mass, a neoplastic mass usually is T2 hyperintense, whereas this lesion, because of its fungal elements which have different magnetic property, they have this characteristic T2 hypointensity on these images. So that pretty much helps us. And if I talk about the epidemiology and other features in literature which also helped us come to the diagnosis, then that is in case of a fungal ball, it usually involves a single sinus, which is pretty much the case with us, because if we look at the other sinuses, they are not involved. And secondly, it usually involves elderly patients who are immunocompetent. You will also find associated features of chronic sinusitis, and the most commonly involved sinus is maxillary sinus as a single sinus, and if not maxillary, the second most common is sphenoid sinus, which we see in our case, and it is typically seen to occupy the anterior part, very often near the ostium, blocking its drainage and thus leading to these features of chronic sinusitis, which led to these inspissated secretion, which is typically hypointense on T2 and hyperintense on T1 weighted images. So there is chronic sinusitis here as well, but that is secondary to blockage by this fungal ball near the ostium. So that is our case, a fungal ball or a mycetoma in the right hemisphenoid sinus with secondary chronic sinusitis related changes. So that was our case. And before I end this video, I would just like to take 1 or 2 minutes of your time, because if you have reached here, then I hope you can have patience for just 2 minutes more. And that is just to tell you that this is my first long format video which I am posting right now on my YouTube channel. And if you think that this was useful, then please show me your love, because it took a lot of effort to make this video. And so if you found this video useful, then please do not forget to like, share and subscribe to this channel, because your encouragement can help me go a long way. And do let me know in the comment section below if you liked this effort, and if you would like to have some different format or some different way of looking at cases, then I'll definitely try to work on that. So thank you for your patient hearing, and see you in the next video.